This is the Motherlands podcast. The intention of this podcast is to provide evidence-based information related to fertility, pregnancy, childbirth, and postpartum, as well as share positive birth stories. I am your host, Keely Semler. There are many factors to consider when choosing the right provider for your pregnancy and birth experience. The midwife, Nancy Beyda, is one of the wise voices of community midwifery care. We discuss what does informed consent actually mean, and how do midwives differ in practice than traditional allopathic doctors. The distinction between treating pregnancy as an illness or something that needs to be cured, and pregnancy as a state of peak health and well-being. Please take note, this is not medical advice. We are here today in the beautiful home of Nancy Beyda. Thank you so much for being willing to talk to me today. I thought it would be really great if you could just start by introducing yourself and letting our listeners know who you are, where you practice, and what you do.
Yes, thank you, Keely. I always love to talk about birth, so thank you for this opportunity. I am a home birth midwife in Los Angeles, and I'm also the mother of 3 children myself. I worked as a doula for almost 20 years before I became a midwife, so I had the opportunity to observe a really wide variety of practices before I went into practice myself. And I've been a midwife now for around 10 years and attended well over 1,000 births over the years. Stopped counting a few years ago.
Yeah, that's a lot.
So I wanted to just mention the fact that I'm a midwife who became one as a result of my own birth experiences. And I had such a positive and empowering birth experience myself with the birth of my first child that it really changed my career trajectory, and it also made me appreciate the value of midwifery. As most of my friends had made different choices about the kind of care they were getting, and I started out with an OB, as many people do who just don't know a lot about the alternatives. And then as I became more educated and I made that change, I saw that my experience was so different from what many of my friends were having, and it ended up being a really transformative experience for me that led me to this path.
Wow, that's amazing. I'm wondering if you can speak a little bit about what makes midwifery care different than traditional obstetrical care. Like, how do you support your clients that might not be the way that doctors traditionally care for their patients?
Right. So I would say one of the key differences with midwifery care is that midwives are the experts on normal birth. We train around normal. We see many, many variations of normal. So we have a kind of broader range of what we accept as normal. And I would say that, medical training in the U.S. focuses on pathology. So especially in like newer OBs, you often see that they've heard of all these scary things and so many terrible things that can happen. And we also learn about those things as midwives. So it's not that we aren't aware of them, but our focus is on normalcy and being finely attuned to how many variations there are on normal and all the ways that can present. And I think that just that kind of focus results in a different type of care, because since traditional allopathic medicine is so focused on pathology and disease and sometimes not really well prepared to deal with health and pregnancy is, for many women, it's like the peak of their health. It's the healthiest they've ever been in their life, and it should be seen that way rather than as an illness or something that is an accident waiting to happen. Most of the time, the very definition of normal is it's what usually happens, and obstetric care in the U.S. now is so focused on what can happen because it's so tied to liability that it's really warped that perspective on to have a focus on pathology and also to pathologize things that are well within the range of normal.
Yeah, that's so true. Could you talk a little bit about the history of midwifery care in the U.S. I mean, midwives used to be illegal. Is it true that maybe perhaps even now, I think midwifery care is illegal still in some states? Is that true?
Yeah, this will tie in, I think, with something we can talk about a little bit more later, which is kind of the range of what risk is, and what is acceptable as risk. Going back not so long ago, the midwife I had, and her partners had been arrested in California in the 80s or 70s and were taken away in front of their families. So that was kind of the evolution of Ina May Gaskin and the farm midwives, and all of those people were part of normalizing midwifery. But the range of what's been legalized in different states is huge. So here in the state of California, we have a really kind of integrated system where we're, licensing is approved by the medical board. But in many states, there aren't any accepted legal licensing, paths available for midwives. So the risk of that is that they don't have access to the same kind of medications and the same kinds of support. They're not integrated in the healthcare system in a way that makes midwifery and home birth safer. And they practice outside those, that system. They're not held within the constraints of mainstream medicine's definition of normalcy, which can be things as simple as people going past 42 weeks. If you're practicing in an unlicensed state, you're sort of already working outside the law, and you are the one making those decisions. Whereas someone practicing in a state like this, California, we are bound to practice within the definitions, the risk definitions that have already been provided by the state. And those kinds of definitions are a big trade-off. Like when they legalized midwifery in California, we had to give up some of the things that people were doing, like breech and twins and other things that were already considered normal variations of birth. Many midwives who'd been doing those for a long time were disturbed by having to give up those things that they were very comfortable and felt safe doing. And it was a trade-off for licensure. So licensure itself is really a complicated question. And then there's also just the traditional question of midwifery as women's practice, community-based, that has been taken away from women, and especially in communities of color, like Black women traditionally were served by their community midwives. We see the result of that now, that is no longer the case, that Black women have these absolutely unacceptable rates of maternal mortality and all kinds of outcomes that are just absolutely abysmal. And part of that is because that community health care was taken away from them. Very pointedly, the granny midwives were made illegal. So it also goes back even further into, if you want to look, the history of midwifery includes all those women who were burned at the stake. There was a high percentage of midwives who were attacked and murdered because they were traditional community-based and sort of nature-based practitioners in their community. So it's a really complicated history. And I think on a deeper level, that reconnecting to that history of women-centered care and powered by women is part of transforming a larger way women see themselves or understand their bodies or even relate to nature and the planet, right? It's the view that women are sold in terms of the way they relate to their body is like sort of a machine that can go wrong, and birth goes beyond being a physical event, but it's a psychological and spiritual event that has a tremendous importance for our planet in terms of healing and how we move forward from where we are.
Yeah. Oh my gosh. As a midwife, you have to assess risk with each of your clients. What are some things that a traditional OBGYN may consider a patient high risk that you may not necessarily consider that patient high risk?
Right. So I think because, again, we have this kind of mechanized view of women's bodies and a tendency to focus on things that are measurable, we have to, in that kind of a culture, establish cutoffs that are somewhat arbitrary. Like I can help with a birth at home between 37 weeks and 42 weeks. Why is 36 weeks and 6 days not okay? And why is 42 weeks and 1 day not okay? Those are arbitrary limits that have been decided upon. And I might not agree with those, but because I'm practicing in a state with licensure, I'm held to those standards. It's the same thing with gestational diabetes, which I consider pretty accurately described as a diagnosis in search of a disease. Gestational diabetes, we have an arbitrary cutoff, and if you're 1 point under that, you're okay. And if you're 1 point over it, you're going to be treated as if you have an increased risk factor. And depending on your care provider, can be considered high risk. And all of those things are kind of arbitrary decisions. Whereas I think that from how I prefer to practice in terms of assessing risk and talking about risk is it's really important that there be a process of truly informed consent. And that isn't really the case with mainstream obstetrical care. In fact, most of the time, they don't even tell women exactly that they have options or why they're doing something.
Well, can you define what informed consent is in your own words? Because I think that this is really important.
Yeah, I think it's really important. And informed consent means that both the woman is truly informed about, for me, it's the evidence. What do we know about gestational diabetes, the true risk? What are the true risks? And why are we doing this test? What are the alternatives to that test? What's the risk of saying no to that test? And basically really discussing in detail why we're doing something. And then allowing the woman to ask questions and make the decision if there is the care provider's, assessment of risk. So sometimes I'll have people sharing things with me that they've gotten from the internet that I think aren't fully informing them about true risk, about something, a decision they're making. And I also have a right to say, this is my comfort level. I'm not okay with doing certain things. And so it's a dialogue. So for instance, I used to be comfortable with telling people that they could skip the gestational diabetes screen if they wanted to and sign the informed consent. However, I had someone who was supposed to be doing it with another care provider, never got around to it, and ended up with this other care provider having a very large baby I could tell this baby was very large, and the baby ended up being 12 pounds.
Oh, wow.
So I would have a different level of comfort around being there, at her birth if I knew that this was just the size baby that she grew, as opposed to someone who was she truly, having this baby is a much larger than her body would have grown if everything had been normal. And because of that, my own personal experience, it changed the way that I practice around that particular question. So when I'm sharing informed consent with people and saying, this is your option, this is why we do it. I'm not really a big believer in, the diagnosis of gestational diabetes because I think it's overused and it's liability based. When I'm sharing that with people, I also now share, and this is why I would like you to do it, because I had this experience. And because of that experience, I practice a little bit differently than I did before. But
I think that's an excellent point that you made, that you get to have a right as a provider to decide how much risk you want to assume in providing care for a client, and that's a conversation. That isn't just, no, I don't do that, or you have to do that. And unfortunately, it's something I experience all the time as a doula and as an educator supporting my clients in a hospital setting, because I have to listen to the doctor basically not give them any options and say, this is just how it is.
Yeah.
And you must do X, Y, or Z if you want a healthy baby or if you want to be healthy. And unfortunately, it's not doing women a service. It's not truly informed consent, which is upsetting because the medical community talks about how important and how, scientific based they are with how they practice medicine. But with that, they should also be practicing informed consent, which means spending more time with their patients. And what is like the average amount of time that a doctor spends with a patient in the room prenatally? Is it like 10 minutes on average, 15 minutes? I don't know. I would say that that's probably the case. So how long are your prenatal sessions with your clients? And I wonder if you could speak a little bit more about, the interpersonal way that you conduct care.
Yeah, absolutely. When I began training as a midwife, first of all, I'd already seen a lot of different styles of practice. There is such a wide range of style between midwives and also, between OBs, but just even between midwives. So I started out training with a nurse midwife who had hospital privileges, and then moved to training later with a woman who was a naturopathic doctor and practitioner. And I really saw the difference in the way they practice. I do all the visits in people's homes, so they are longer, and there's the time and space. I usually allow at least an hour and integrate other family members into the process. And it's a really conscious decision that takes more time on my part, but it gives the opportunity to really discuss in depth things like, here's truly informed consent. Here are your options. Mm-hmm. What do you think? And have time to also, just the space to sometimes see things that are in their life that I wouldn't have known about otherwise, that I believe will have an impact on their birth, and things that need to be discussed. I see the way they eat. When I see the level of stress they have, I see the kind of household support they have for postpartum, or, all of those things. Sitting on someone's couch and talking with them in their own space just creates a different relationship that I really love. And I treasure that ability to have that. So I have to keep my practice to a certain level to be able to have that amount of time to spend with people. But over the years, I learned it as a doula that all of the work that I did in advance, being proactive and addressing things that I started to know were issues, whether they're physical issues, but psychosocial issues and issues with their relationship, all of those things come to bear on their birth. Mm-hmm. And so having the space to address them in front can both save you time from having to go through that process during the birth and work through things, or, being underprepared to really address them postpartum. And so that time is, I think, one of the real joys of midwifery practice, is being able to have those kinds of relationships with people. It's very special, and you almost feel like, they're a family member for life in most cases.
Totally. Yeah. So you work in the home, you get to know your clients intimately. Some people confuse the terminology here, people that are unfamiliar with midwifery care. So I'm wondering, how do midwives differ from doulas? And what are your thoughts around doulas supporting, patients?
Yeah. So midwifery we're the equivalent of medical care. We're the equivalent of an obstetrician in terms of providing all the prenatal health care, typically lab tests, everything like that. But as I mentioned, it's a little broader since we're also looking at other psychosocial issues. We follow the same visit of care. So we're seeing people typically once a month earlier in their pregnancy, offering all the testing, but talking about it like, this is what you can do now. These are the tests that are available. And then, and really, what do you want to do? How can I support you? And then when it comes to the birth, we're the ones who are responsible for the medical well-being of the baby and the mother. And what that translates into is I can provide suggestions like, try squeezing her hips this way, or why don't you try moving this way? A doula's role is of support and mothering the mother and being in that position. And I can't do that and do well what I need to do in terms of being really aware and watching over the mother and baby's medical well-being.
Right, because you're doing the fetal heart tones and you're charting. Yes, that makes sense. So hopefully that clears things up for people that get doulas and midwives confused.
People also sometimes think that a midwife replaces a doula. And because our roles are very different and complementary, they are both a really important, the ideal for people who have the resources to do it. And I think in our country, it would be cost effective to make sure everybody had the resources to have a doula wherever they're birthing. But that is the ideal situation for me, for a healthy, normal pregnancy, is you have a doula who is there to be your physical, emotional support, and then also the midwife who is there to be your emotional support to a certain extent, but to watch out for your baby and your well-being.
Yeah, that makes so much sense. Like a midwife is going to be busy paying attention to the baby and the mom in labor. So a midwife cannot do the role of a doula, and a doula certainly cannot do the role of a midwife. As a doula, for me, sometimes I run into a situation where I have a conversation with a client and I'm trying to educate them of what their choices are and truly give them space for informed consent. Sometimes when they make their decision, it might not be what is recommended. But as a doula, I'm not liable and it's not my place. So I'm wondering, as a midwife, how do you navigate that when you have a client who you inform them of all their options and they're kind of biting at the one option you're hoping they don't choose just for the safety of them or their baby? How do you approach that?
This is one of the reasons I became a midwife, is because as a doula, you're in a bit of a competing role with they're getting maybe information from a care provider that doesn't align with what you're telling them. And ultimately, that complicates things, right? Mm-hmm. So one of the things you learn as a midwife is that there are advantages to having concurrent care with, sometimes people that I'm seeing are going to Kaiser, for instance, because they have an HMO and they have free tests and everything there. Mm-hmm. And it's fine if I steer them towards the right providers at Kaiser who are in alignment and maybe they know me and they trust me. It gets to be a problem if, even as a midwife, if my midwifery client's seeing a provider that isn't in alignment with the values, and isn't giving them the same advice, then that is going to create a conflict. But as a doula, they are clearly ultimately the medical advice can be seen as the one that's the authoritative, expert advice.
Right.
It comes down to a certain point also of what resonates with them, right, and their own belief system. So you might give advice to or share information with someone who that would kind of open their eyes and say, oh yeah, this provider, I remember he said this to me and I realize I don't completely feel like he's going to listen to what I want. Or you'll have someone who will say, like internal dialogue, I just don't feel comfortable changing, or this is too, or I want to give over basically my authority to this other care provider. I'm going to trust them. I think, that competing thing is a little different with doulas and midwives, but ultimately, as you see people make those choices, it does give you a lot of information about where they are internally, in their own process and their own growth process. And sometimes they have to go through a really negative experience of not listening to you and being afraid to do what they really want to do, or giving away their power, or trusting someone who isn't worthy of trust. And that's actually a lesson on their life journey. And you have to see it in those terms. And it's really hard to watch sometimes heartbreaking outcomes of that choice. But you do always ultimately see it from the context of their own choices they've made, right, that lead into that outcome.
Yeah. And I think that is a really humbling reminder for all birthing people, is that despite the outcome of your birth, you still made choices. There are outliers. There are people that don't have insurance.
Right.
And I'm not talking about those. I'm talking about people that consciously choose a provider and have care. You don't get to choose the outcome of how your birth goes, but you have to own the choices you made with your experience. And sometimes that's really traumatic and very hard to reconcile.
Right. And sometimes the only thing to do is to say, what is my lesson from this? And that's also kind of tricky to say that, because in a way some people could say you're blaming them for, and sometimes things are totally out of your control.
Yeah, and it's not their fault. You
Right.
know, this isn't a blame game. Again, it has nothing to do with the outcome of what happened, but if you're consciously choosing someone to guide you through that experience, that's something. When I have a client that's like trying to determine if they want to have an out-of-hospital birth, and they ask me the difference between a doctor and a midwife, one thing I point out immediately is that an obstetrician is able to perform a cesarean or surgery, whereas a midwife is not. But in terms of how a midwife is trained is similar in terms of clinical hours and hands-on experience. It's just not in like a lab or in a medical school. But there is medication that midwives can use in out-of-hospital birth settings, so at home. And one of those medications I think would be very interesting to talk about, and that is Pitocin, because a lot of people assume that Pitocin is only used in one way, which is in a hospital setting during an induction. But there are actual real reasons to need to use Pitocin out of hospital that midwives are permitted to use. So can you talk a little bit about that? We don't have to go too in depth about it.
One of the things I always tell people when I'm speaking to them for the first time or interviewing with someone is explaining that here in California, as a result of the fact that we are licensed by the medical board and we're working within that system, we have access to basically all of the medications that they have at a hospital for certain things. So we carry oxygen and IVs. We are listening to the baby with, typically with a Doppler, and we carry all of the medications that they do, but we don't use them during labor. Like Pitocin is an example of a medication we carry, and we use it for postpartum hemorrhage. Mm-hmm. We don't use Pitocin and we don't give epidurals or narcotics because those things increase the risk, and it takes it out of normal to where you need a different level of surveillance and
Right.
a different ability to follow up quickly when things, if things do go wrong, if there's a problem. So we carry all of the medications. Pitocin we only use for postpartum hemorrhage, but we have 3 other medications that we also carry because bleeding is something that we respond to really quickly. Mm-hmm. And Pitocin is usually the first one we do. In states that aren't licensed, they typically are using other things to respond to postpartum hemorrhage. Like I learned about Yunnan Bao, which is Chinese medicine from midwives in unlicensed states, but they also use everything from the placenta, right, to the umbilical cord. All of those are things that are natural remedies, as well as herbs. We have lots of herbs that we use.
You mentioned tearing, so midwives have the ability to do repairs similar to the way that an obstetrician does, right?
Yes, so midwives can do repairs. We're trained to do that. We also have a real emphasis on avoiding tearing. So we are very focused on both prenatally, talking about ways to avoid tearing. And those are everything from nutritional to talking about pushing and how to slow down. Women are rightfully really concerned about how do I avoid tearing.
Oh my gosh, every one of my clients, it's like, I don't want to tear.
I don't blame them, right?
Nobody wants to tear.
Yeah.
But that requires patience and
Yeah.
to go slow and to listen to your provider say, slow it down.
I also think it is important to have the ability to choose your position for pushing, because women intuitively get into positions that sometimes like, oh, why is she doing that with her leg? But it also, that extends to being on their hands and knees or other things that take pressure away from their perineum, which is where most people have the tear. Mm-hmm. And I also find that birthing in the water, for me, seems to help many people with a kind of counter pressure that's natural. There are a lot of things we do to avoid tearing.
Yeah.
But we suture, and that means we numb somebody really well before we do that.
Due dates, what do you think of them? And I know there are different ways to calculate them, and most people are just go to the doctor, they do an ultrasound, and they're given this arbitrary date. So what are your thoughts on that?
Right. It's another way that we've really tried to sort of institutionalize medicine or institutionalized pregnancy in a way that these numbers like paying so much attention to people, how dilated they are. And those are all ways of sort of trying to turn something that's not an objective experience in many ways, because there's so many pieces of it, into something that can be measured. Due dates are responsible for a lot of the problems that I think some of the most extreme, issues that we face now in terms of the way mainstream obstetrics are practiced, because of that rigidity about the way people respond to due dates, and especially since the ARRIVE trial, which came out a few years ago, that, basically said the way to reduce the C-section rate was to induce everyone at 39 weeks. Due dates are very arbitrary, but with ultrasound, there's, when they're established early, it's also something that they're saying, well, this is really, a valid date. As a midwife, one of the first things I do when people come into care is have a real conversation about, how did you get this due date? What were the things that they looked at to say, when you actually conceive, because cycle length is one of the things that really impacts due dates. So I'll always see if there's other, especially with a first baby, say, are there other things that we can look at that might give us a different due date that's later, just because we know that 42-week cutoff is a hard cutoff here in California where I'm practicing. So having a really in-depth conversation and using other ways of establishing due dates, like the Woods-Nichols rule is one that I use that takes into account cycle length. Mm-hmm. But the truth is that just like everyone might have a baby that would walk at a different time, if I said, oh, your baby should be walking, at this date, well, there are families that have developmental just differences in the way that these things happen. And that also includes gestational, length, because there are many, many families that traditionally everybody just had their baby at 43 weeks and it wasn't a big deal. So now it is a big deal because most practitioners are really uncomfortable letting you go that long. Mm-hmm. And that risk, it comes back again to that conversation about risk and people making their own decision about what kind of risk they're willing to take, as well as caregivers, rather than it being a hard cutoff. I think that would be helpful, because when you look at the real risk increase at 42 weeks, there is a risk, but it's a relative increase, right? It's not like, it's still like
pretty minuscule.
Out of 1,000, it might. But at the same time, if it's your baby that's stillborn, that was way too much risk. So who gets to make that decision? I think it comes back to the woman and informed consent. And due dates are definitely a big problem. Well, the reason they're a big problem is this huge percentage of people are getting induced right now, and we all, anybody who practices knows what that leads to.
Right. So just within your own practice, using your years of experience, all of your clients, can you give us a rough estimate of how many first-time moms go past their estimated due date?
So the average length of first pregnancies as well, it's closer to 41 weeks. And right there you can see that we also, part of it is our culture's problem around wanting something, it's hard to wait after a certain point. And everybody's calling you and they're asking you, oh, I thought the baby was going to be here on Tuesday. And you're like really done. So it makes you very vulnerable to wanting to do something. But if you let people go to just when their body is going into labor and their baby's ready, it's a really complex dance of hormones that, between your baby and your body, when both are ready, everything, it links together and there's this beautiful flow, right? The way things work. But when you intervene, it definitely raises other issues.
I look at it from my perspective as a doula. I have to remind clients all the time at the end of pregnancy that being anxious or stressed is signaling to the baby, don't come.
Right.
And it prolongs the whole experience. So it's like the more people can feel relaxed and at ease, which is way easier said than done.
I know.
You know, the chances of someone going into spontaneous labor is a lot higher just because their body is relaxed and they're not in their head trying to pick apart or try and control really the experience.
But how hard is it to say there's nothing more stressful than feeling like I really shouldn't be stressed? So
I know
it's and everything around them is contributing to that, and it's so difficult.
So what do you do with clients that are 41 weeks and 5 days? And, you know, do midwives have a way to naturally induce labor? Or do you just say, sorry, gotta switch you in a doctor's care now? Like, how do you navigate that?
So I try to not make much of an issue of it till around 41 weeks. And I do remind people that 41 weeks is, you know, closer to the average length of the first pregnancy. And around 41 weeks. And then I say, you know, there's a lot of things we can do, and we're going to do those in this order. And you're going to be the one making the decision what you want to do, or if you just want to wait. And here are all your options. And I have a whole range of everything from like, yeah, you can start doing acupuncture. You could go for reflexology. You can do a massage, and you can have lots of sex and go for lots of walks. And then from there, we have a whole list of things that ramp up. And we also have the midwives cocktail, which is very effective for people. And I leave it up to them. I say, you can wait until you're right up to the finish line. You can do it because it's their decision, what they feel comfortable with. And I have had people who wanted to do something even before 40 weeks. And that's kind of hard for me, not, you know, to say, because they were very anxious to have their babies. But then I had to remind myself that they really are the experts on what's right. And it went great, you know.
Oh, wow.
I'm not a first-time mom, but it's just giving people a lot of information and stepping back and releasing the results and saying, this is everything. And they're going to ultimately make the choice of what's right for them.
Yeah, totally. Yeah, I know that cocktail to be so helpful to some of my clients. It's amazing. And if anyone is listening that is, you know, interested in that, I'd be happy to share it if you're okay with that.
Of course, yeah.
I think now would be a good segue into if you're open to sharing your first birth experience. I think you've shared a little bit of your story with me before, whatever you feel comfortable sharing with it. One thing that before you share your story is the context of these time limits that the hospital gives for pushing the baby out. In California, or at least in Southern California, where I practice as a doula, there's this arbitrary time limit of 4 hours. And it's not just hospitals that do that. There are some providers, some midwives that also have a time limit. So I'm wondering if you could have any thoughts on that, and maybe you want to share your story and then also give your context with that question. But if you could, you know, if you're open to sharing what you think of time limits in terms of how labor unfolds.
Right. The way that I practice comes out of my core belief system. And that belief system is that labor works perfectly the less we do to it, and that the body has a wisdom, this innate wisdom that should be respected. But as a midwife, my role is to differentiate between what's normal and is part of that spectrum of normalcy that can range, and what is a problem. And there are subtleties to practicing that way, and it isn't an arbitrary cutoff. And part of that grows out of my own personal experience. So with my first birth, I labored for I started with early labor on Friday night, and I'd taken the Bradley method, which was great. And I knew that, I remember looking in my book and thinking, I'm a putterer. So I'm kind of puttering along, and I was resting that night. And then all during the next day, my husband had made me this really beautiful playlist that we still have. It's very sweet. He still plays this jazz piano for me. It's really beautiful. Aww. And then Saturday night, I was also and we didn't really tell my midwives. So I was just going along, and on Sunday morning, I got into the shower and I was shaking, and my husband called the midwives just to tell them what was, and they were like, get in here right away. because I was birthing at a birth center the first time.
Oh, okay.
So we drove into the birth center.
Was this in LA?
Mm-hmm. I actually felt the challenges to my birth came when I stepped into that, into that
space,
in their space, because I ended up being complete when I arrived, and for whatever reason, I didn't really feel an urge to push. And I think that there was a natural thing that came out of them. They just wanted me to, get going and for them to not be there all day. And so I ended up pushing for 6 hours, and with them wanting to transport me multiple times and me just saying, no, I won't do it. I don't want to go, because the baby was fine and I was fine. In that case, obviously, if the baby was showing that was a problem,
that's different.
Then that would have been different. But I realized afterwards that I had a baby that was asynclitic. That means her head was tipped, so it was
sideways,
a little wider going through. And what I learned from that experience is when I do things in advance of labor to help the baby into the best position possible. And of course, sometimes it's out of your hands and they have their own ideas about what position they want to get into. But it also made me feel that there shouldn't be an arbitrary, limit, because I ended up very triumphantly. In fact, maybe that was why it was so empowering. I sort of felt like I did it despite you all saying, don't. Amazing. And because I wonder sometimes if I hadn't been pushed into starting right away to try and pushed into pushing, that baby might have, repositioned her head, or we might have done some rebozo work, or there might have been other alternatives. So what I've observed over the years also is that there are often periods during labor where things slow down for reasons that we don't necessarily understand at the time. And if someone's in the hospital and they're given Pitocin because they're not meeting some kind of arbitrary timeline, then sometimes there are issues where actually the body naturally would be accommodating a short cord. So the things I've seen over the years are like, the person's labor slows down. Well, is this a kind of rest and renew before she starts pushing? Is her body giving this cord time to stretch and then pushing the baby out really quickly? I've seen that before. I've even seen people whose labor stalled, and then when they pushed, the baby and the placenta came out together because it was such a short cord. So that body was basically waiting until it was ready to just eject the baby. And then, otherwise they would have had... probably the baby wouldn't have descended if they would, and they would have seen, issues with the heart rate if they would have given Pitocin to speed things up. So I've seen a lot of cases where the body had a wisdom about what it was doing, and having those arbitrary kind of definitions of normalcy didn't make sense. At the same time, you have to have the experience to differentiate between what's normal and what's not, because not everything is normal, and there are such things as problems, and to pretend that doesn't exist, I think, is the far spectrum of kind of a reaction to what we have, where, anything that's not in the 50th percentile is not normal. Yeah. Where the issue I have with free birth is, although I think that everyone has a right to make their own decisions, I think that it can be glamorized online, and there's no one who takes responsibility when there's...
Can we quickly define free birth? Because I think there's probably someone listening that's like, does that mean that you don't pay for anything?
I wish that it meant that. I'm a total proponent of that kind of free birth. I think it's one of the, real crimes that most women don't have access to midwifery care, because actually midwifery care would be the most cost-effective way. Like, have every woman have somebody come to their house afterwards, you know, and watch out for them, and also just to, it should be the norm, right? Yeah. But free birth means that you give birth without any trained attendant. While I do trust that women I do think that women definitely have the right to make that choice, I also think that it can be glamorized in a way that undercuts, the risk that they're taking. So they do need to have also a real idea of what the risks are, because things do happen where having a trained attendant is important to respond and be safe.
And by attendant, you mean doctor, midwife?
Doctor, midwife, or somebody who knows how to handle emergencies. And basically, like we spoke about postpartum hemorrhage, that's something that I think can happen
What are your thoughts on just the physiology of giving birth alone versus having someone there?
Yeah, I think that women traditionally were supported by other women from their community, and usually there was a woman who had more experience with birth who was there as well. I think the ideal is to have, it's kind of what Michelle O'Donnell said about the midwife who's sitting in the corner knitting. I think that what's happening in terms of not wanting anyone there is in some ways a reaction to the fact that too many midwives also are an intrusive presence, and that they should be in a role of being this quiet presence that's reassuring and doing the least possible as long as birth is going well, and being trained to recognize when there's something that they need to do. But really, I think that birth works best the less you do, to just allow the normal physiological processes that are so amazing. The more you look into each piece of it and see the complexity of the way our bodies are designed and how everything works so perfectly when it's respected and supported, having people there who are reassuring in that sense, when you do feel like, is this okay? And having that person there is available is the ideal. But I recognize that not all midwives or physicians meet those requirements of being that.
Well, and if they've had experience with things going bad,
right,
then they're not going to feel comfortable hanging back and trusting and being a little bit more non-interfering. I think that's why I absolutely adore you and love doing births with you, because to really watch you support people and be that loving presence, but really just be on the sidelines, I think that gives a birthing person so much space to claim for themselves and really kind of work through things and focus through things. And then you're there if they have questions, but just the quiet reassurance and confidence of just not disturbing them unless they need something, right? Which is super rare. I mean, I've practiced with a lot of midwives, and there's no one like you is what I'm trying to say. You're one of a kind, truly, truly. And I know that absolutely must have a physiological effect on women, because they have the space to really work through things and not feel like they're being told what to do, or that, it's like some secret formula and you have to do this, this, and this to have your baby.
Right. Just because I can do it doesn't mean I need to. And I once had someone say to me, another midwife said, well, I'm not afraid to do a vaginal exam. I'm not afraid to do a vaginal exam. And for one thing, I felt that language was very judgmental of me preferring not to do a vaginal exam. It wasn't that I was afraid to. I need to recognize that a vaginal exam is more than just a vaginal exam. It's also a kind of intervention. And
it is.
Is it an appropriate intervention? Yes, it sure is if you need to do it. It's really common for me at a birth to have to almost sit on my hands to stop myself from wanting to check. And I think to myself, what if in half an hour, if I see that nothing's changed, maybe I'll reconsider this, but let me just watch all the signs. And there's so many signs of progress in labor that once in a while when I'll work with someone who is doing a lot of vaginal exams and not watching it, or when I'm forced to, like a doctor will say, like, how dilated is she? Or when I have, somebody ask me and I'm like, I don't know, because I'm not checking. I really don't want to check because I'm watching her, and I can see why the way her labor is moving, get a really good sense of what's going on. And 4 centimeters doesn't mean that she's not going to be 10 centimeters in 10 minutes, or that she's not going to take 10 days to get to 10 centimeters.
Right. Yeah, that's such a good point.
So I really, it's a conversation I have internally when I want to kind of know. And then I have to remind myself that doing that exam often isn't knowing anything. Sometimes it is giving you another valuable piece of information, but I only do it as an intervention if I have a question about normal. It's another piece of information about normal.
I like that you approach vaginal exams if you have a question about if you're on the fence of what is normal.
Yeah.
I love that because, well, most doctors want to do vaginal exams starting at like 38 weeks.
It's nothing. It's seen as nothing. It's a lot. It carries a heavy
It's
message.
invasive
It's
too.
invasive. It's also, the message is, again, that kind of, if you're focusing on that one piece of information, you're ignoring all these other things.
This huge picture. Yeah. Because it's such a small, tiny fragment. A vaginal exam, you're literally only feeling the cervix and possibly the station where the baby's head is in relation to the pelvis. But we have no knowledge of what's actually happening internally. That's way more subtle.
And there are so many ways that progress unfolds in labor, that keeping that attention on a number. It's something that's numerical, and it's very much a part of our culture's focus on what can be quantified. And yet, again, I think besides that fact that it's only one tiny piece of information, you don't want women's brains to be in that place during labor. Because the last part of her brain that I want to kick in is the one that's thinking,
fight or flight.
And in terms of number, and that part of our brain that's not the intuitive piece where
the analytical, the logical, which there's nothing about birth that is logical.
Right.
There's a sense of intuition, but not like this is follow these steps like it's in a manual.
I really try to discourage that part of the brain. And it also is whenever you're every time that, say in a hospital, that a group of people is coming in and they're all talking and what did you last have to eat and making all those are all just basically like activating the part of her brain that I don't want to be, activated. And everything that I can do, and the other reason why I try to be really quiet is because I really want to give her the space for that primal intuitive brain to flourish and kick in and take over.
For anyone listening that is wanting to conceive or recently found out that they are pregnant and they're listening to this going, I've never thought about having an out-of-hospital birth. What might you say to them to help guide them in asking themselves some questions about if having a midwife or an out-of-hospital birth could be right for them?
Well, I think first of all, when you're newly pregnant or you're considering conceiving, it's a journey to find the right match for you. And honestly, out-of-hospital birth is not the right match for everyone, nor is hospital birth the right match for everyone. So don't feel like you have to be at the end of your journey and have clarity, but recognize that it's going to be a journey and you're going to be gathering information. So start reading some books that talk about Ina May's Guide to Natural Childbirth, or, is a good just kind of introduction to considering why you might. Taking a good childbirth education course is crucial too, to exploring. I think a lot of people passively just accept the idea that hospital birth is the norm, and so they don't even explore what really that might mean for them.
Right. Or the hospital just offers a childbirth education class, which isn't.
It's like a rubber stamp of like, this is what we're going to,
this is how you be a good patient.
Right.
This isn't like, this is what's happening physiologically. These are your choices. No, it's like, here are the drugs. Here's what the room's like.
Yeah, that goes back to informed consent. So to have truly informed consent, you need to have a more objective overview of what your options are.
So maybe taking a childbirth education class that's not affiliated with a doctor.
Huge. Because I know people who've taught childbirth education classes that were affiliated with a hospital, and they said, I can't even tell women that they could get in the shower. I'd get in trouble. So they can't tell them what their options are because they know that they're going to get in trouble if they do that. So that's really important. Having a doula is huge, whichever, because they're going to help give you information as well. Again, that's a luxury for a lot of people, but hopefully now here in California, I'm hoping that with Medi-Cal covering doulas.
Actually, a girl I'm mentoring, she just got approved for
Amazing.
that. So she gets a little reimbursement for taking Medi-Cal.
So happy
clients,
that that's happening. Yeah. So those are all things that make a big difference. But but really exploring your options and knowing that there's no right answer for everyone. That's where you feel most comfortable. And then, but also being aware of the realities of each situation and what it really involves is important.
Thank you so much. This has been so informative. I'm sure people are learning a lot just from hearing your experience and your expertise. I'm so grateful for you and everything you do. And I know that you have just impacted just thousands of families. And it's just such an honor to know you. So thank you so much for being willing to chat.
Oh, well, it's an honor to do this work. It's the most rewarding work that I can even imagine.
I'm so glad it found you.
Yeah, it found me for sure.
Yes, totally. Thank you. Thank you so much for listening. If you enjoyed this episode, feel free to share with friends and family and stay tuned for the next episode.